So hello and welcome everyone to this webinar about the general principles for coding of medication errors and other types of deviations from the labeled medicinal product use. I'm Karen Wilson and work as a medical officer at the MSSO, and I will be your instructor today. And I'm supported by my colleague Jane Knight, who was speaking to you before. So together we will take you through this webinar, which will last for about 2 hours. We would like to make this webinar interactive. Jane mentioned this already, so please submit your questions or send us your comments through the question panel that you can find in the control panel on the right hand of your screen. And I will allow as much time as possible for questions both during the course and also at the end of the presentation. But please do not raise specific coding questions, as we can't help you with individual verbatim terms. We will rather guide you in terms of coding principles. Now let me start with the presentation. You all know that ICH adopted the development of MedDRA mid of the 1990s and became the owner of the terminology. ICH then, on contract, appointed the MSSO to take care of the maintenance and further development of the terminology based on user feedback, to provide and organize corresponding training as the one that we have today, and to administer the MedDRA licensees. And all these MSSO activities are overseen by the ICH MedDRA Management Committee. ICH is not only the owner of MedDRA itself, but also owns this training material. It is protected worldwide. You may use the slides with the exception of the MedDRA and ICH logos, but will have to clearly indicate that ICH owns the copyright. Also, any adaptations of the slides have to be clearly labeled. The second bullet point on the slide refers to warranty and liability issues you should be aware of. And the second one, excuse me, the third bullet point is not relevant for today because we will not be using any third-party slides. Now let me provide you with an overview on what we will cover in this webinar. At first, we will explore the regulatory background for today's topic. We will then discuss definitions and terminologies for product use concepts based on the ICH guidance documents. And after that, we will look into the general principles for coding of medication errors. And then apply these principles in exercises using the MedDRA browser. And we will conclude with a question and answer session, as mentioned at the beginning of the session already, but we will address your questions throughout the session as well. So this slide now explains about the quiz questions, the polling that we will use during the webinar. The easiest way to join these activities is to scan this QR code with your smartphone, and it will bring you directly to the poll. And as soon as I activate the first question, you'll be able to see it and respond. Or alternatively, you may enter the indicated web address, paulf.com, here you see it, into the URL bar on the top of your internet browser, in your computer, tablet, or cell phone. It will then take you to this log on screen here, and you'll be asked for a username. The poll is completely anonymous, so you don't need to enter your name, but please enter my credentials as the username, that is Carol N. Wills 584, with no spaces, and then click join. I just leave this on the screen for a moment so that you can enter the required information, but you will also be able to see these credentials on each slide that refers to the quizzes. And Jane already mentioned she has put this information in the chat as well. Should you lose connection to the poll during the session, please let us know, and we will be able to help you. So let's see whether it works. Where are you joining from today? Where are you located? I see many people from Europe, India, South America, Latin America. Bon dia. I see Philippines, many in, is it Turkey? So I see Greece, Spain, buenos dias. difficult to differentiate all the countries in Europe. Japan, Brazil.
Caroline, we've even got someone on the chat from Australia.
Oh, welcome. So nice to meet you all. We have a global attendance.
Yeah.
Somebody from Africa we are missing Africa, Jane, but otherwise it's a huge distribution. So for some of you, it's really early in the morning. For others, it's quite late already in the day. So welcome all. Oh, Africa has joined as well.
Oh, good. Really global, right?
A global attendance, yes. So nice to meet you all. And now let's start. It seems to work, our poll. So let's get started with our topic, that is medication errors and other product use issues. And we will first look into the regulatory background, because this is an important topic that is in focus of many regulatory authorities around the world. Medication errors are a critical and important problem in healthcare, and they are not only of great importance for the patients concerned, but also have a huge impact on healthcare costs. They represent the most frequent preventable reason for adverse events in the use of medicinal products. And since they are actually preventable, they are in the focus of regulatory authorities. Depending on countries and regions, they support the recording, coding, reporting, and evaluation of these errors in order to gain new insights into the extent, first of all, and also the causes of medication errors, with the intention to develop improved strategies for their prevention, to better, firstly, protect patient safety, but also to reduce healthcare costs, because the costs associated with medication errors could much better be invested in other areas of the healthcare system. The fact that medication errors are in the focus of regulatory authorities is also reflected by new guidances that have been published or are in preparation. You may already be familiar with a good practice guide on recording, coding, reporting, and assessing medication errors of the European Medicines Agency, just one example. And also the FDA has published various guidance documents to help avoid medication errors. And you can see some of them here. So a guidance for the submission, for the evaluation of proprietary names, best practices in developing proprietary names for human prescription drug products, etc., etc. And as stated earlier, regulatory requirements may differ between regions. So make yourself familiar with your local requirements. These are just examples. The regulatory initiatives mentioned have also led to the addition of new terms to MedDRA, together with a restructuring of the hierarchy to better support specific coding on the one hand side, but also subsequent data retrieval and assessment of medication errors and other types of product use issues. And they also led to updates and amendments of the relevant points to consider documents to provide more guidance for these coding scenarios. You may think that this topic is only relevant for the post-marketing area, but this is not the case. It is also relevant for clinical development, for clinical studies. As an example, in May 21, FDA and the Reagan-Udall Foundation for the FDA convened a virtual public meeting on the potential medication error risks with investigational drug container labels. The risk of medication errors related to the content and format of information on investigational drug container labels was explored, the prevalence and nature of medication errors, and practices that might minimize the potential for such errors. The recorded event is still available on the web if you are interested in it. So are there any questions so far, Jane?
No questions so far, Caroline.
Okay, then let me continue. As mentioned already, the PTC documents have also been updated. So the ICH guidance documents and supplemented to provide more guidance and assistance to MedDRA users on this topic. Let us first look at the MedDRA term selection points to consider document. Here, the cover page of the latest version of the document that was released in March this year. And if you look into the table of contents, you will see that the guidance for medication errors and other product issues like misuse, abuse, addiction, plus off-label use is quite short. This is different with the MedDRA PTC companion document that provides more detailed information, examples, and guidance on medication errors and the other types of product use concepts. It is a living document that is updated as needed. It is not newly released on the 1st of March of each year, like the PTC document for MedDRA term selection. So the latest release, 2.0, is from October 2020 and is shown on the slide. Here you'll find much more detailed explanations and instructions. I can only recommend taking a close look at these 25 pages because they are really very helpful to better understand the terminology and classification of such events with many practical examples. So now let me show you where to find these documents. I will switch to the MedDRA website and how to use support documentation. Takes a while. Here we are. And right on the top, you find the points to consider documents here. And here is the MedDRA term selection points to consider document, and also the companion document that you can download from the MedDRA website. Before we go into further details, we will have to familiarize ourselves with the terms that refer to medication errors and other product use errors and issues. Here, a definition of the term medication error. A medication error is any preventable event that may result in the improper use of medication or even harm to the patient, while the medication is under the control of those involved in the medication process, meaning physicians, pharmacists, nurses, patients, consumers, or their families. The second aspect that is highlighted in green is important to remember. These errors occur during product use in the medication process, when the product is under the control of the healthcare provider, patient, or consumer. The term does not refer to errors that occur during manufacturing or are caused by wholesalers, for instance. In other words, outside of the control of the healthcare provider, patient, or consumer. Medication and other product use errors may be related to professional practice, the products themselves, and healthcare processes and systems, including prescribing, communication of orders, product labeling, product packaging and nomenclature, preparation of products and their dispensing, distribution and administration, as well as related education and product monitoring. Here's the link to the respective definition where you can find it. The PTC document for MedDRA term selection contains a table on page 31 that facilitates a high-level classification of product use errors and problems. And 3 criteria are used for this purpose. Was the deviation intentional, a conscious decision, or did it happen in error? Was it unintentional? And who has caused the event? Who triggered it? The patient or consumer, or the healthcare professional? And did it happen in the context of therapeutic use of the product? Yes or no? So misuse, abuse, addiction are always intentional. They're always triggered, caused by the patient consumer. The misuse is for therapeutic purposes, whereas abuse, addiction are not for therapeutic purposes. A medication error can be caused by either patient consumer or the healthcare professional. It is, of course, accidental, non-intentional, and also happens in the framework of therapeutic use of the product. Off-label use is only triggered by the healthcare professional. It is always intentional and for therapeutic purposes. So the asterisk here, when it comes to misuse, is because definitions of misuse may not always include the concept of therapeutic use. Misuse may be also similar to the concept of abuse in some regions, like for instance in German-speaking countries. So nomenclatures may change depending on regions. Let me illustrate these scenarios with some practical examples now. Here we have Lisa, and she has stress at work. In the first scenario, the doctor prescribes 1 tablet of a sleeping pill a night to help her sleep better. But since she is still awake at 3 o'clock in the morning, she decides to take another tablet. This is a conscious decision on her part, a deviation from the prescribed treatment regimen for therapeutic purposes. In other words, an intentional misuse of the medication and intentional drug misuse. In the second scenario, a friend advises her to look for painkillers on the internet to calm down. She orders the medication and takes 1 tablet a day at first, but then continuously increases the dose to 4 tablets a day by now. Here we also have a conscious decision by Lisa to take these painkillers to calm down, so she deviates from the actual therapeutic indication because she's taking painkillers, and gradually takes too much of them. And this constitutes a product abuse, here a drug abuse. In the third scenario, Lisa does not tolerate the sleeping pill. She is dazed after waking up. So the doctor prescribes her a painkiller off-label instead. Here we have a conscious decision by the doctor for therapeutic purposes, and we also know that this is an off-label use for an unapproved indication, an off-label use of the product, the medication. Please note that 3 criteria which are required for the high-level classification as off-label use are met. But for coding purposes, additional information is needed to finally code to an LLT under PT off-label use. Off-label use has to be explicitly mentioned in the verbatim or case in order to be able to code this information accordingly. Why? Off-label use refers to the unapproved use of an approved drug in a specific country. And this information is not available for coders in most instances. Coders shouldn't make this decision unless off-label use is explicitly reported, as I said, in the case or even in the verbatim. Related guidance can be found in both the PTC document for MedDRA term selection and the PTC companion document. And finally, in the fourth scenario, Lisa suffers from forgetfulness due to the stress she is experiencing at her workplace. She also forgets that she has already taken her medication one day and takes it a second time. This is unintentional, accidental, but happens in the context of therapeutic use. And this scenario now represents a medication error. The following flowchart visualizes this decision-making process. Here are firstly the 3 core questions: intentional or accidental, unintentional, caused by whom, and in the context of therapeutic use, yes or no. Let us assume that the unapproved product use took place intentionally. This may be decided by healthcare professionals or by patients, consumers. If this is a conscious decision by the healthcare professional and for therapeutic purposes, we classify these events as off-label use. These 3 criteria are required for the high-level classification as an off-label use. But remember, additional information is needed to finally code to an LLT under PT off-label use. Off-label use terms should only be selected when off-label use is specifically mentioned in the reported verbatim information. If an intentional deviation from the product information originates from the patient or consumer and happens in the therapeutic setting, we classify this an intentional product misuse. If the deviation does not occur within the therapeutic use of the product, the deviation is classified as drug abuse or drug addiction. If the unapproved product use is accidental, this can also be caused by both the healthcare professionals or patient consumers. If this occurs in the context of the therapeutic use of the relevant product, it is classified as a medication error or product use error. You may now argue that in many cases, it is not clear whether such a deviation was intended or unintended. Here you can see an example for such a scenario. It is reported that the patient took an extra tablet before going to bed. So, did the patient misunderstand the doctor's instructions or the package leaflet? This would then represent a medication error. Or did the doctor mistakenly give her the wrong schedule with a prescription? This would also represent a medication error, in this instance, a prescribing error. Or is the patient's discomfort getting worse at bedtime, and so she decided to take one more tablet? This scenario would constitute an intentional drug misuse. Or did the doctor decide to use the drug off-label because he was convinced that the treatment would be more effective this way? Our case information here does not allow for any of these classifications. So what can be done when getting similar reports for coding purposes and when no further information can be obtained? Now, for such coding scenarios, MedDRA contains very vague, non-specific PTs. If it is not clear whether such an event happened by mistake or intentionally, a suitable LLT under the very vague PT product use issue can be used. Very general term. And if it is not clear whether an intentional deviation from proper product use happens for therapeutic reasons, a suitable LLT under the PT intentional product use issue can be selected. Again, a more vague term. But you would capture the information that it was an intentional deviation. So the flowchart shown before must therefore be expanded with these 2 neutral, more general terms shown before. You can see the question marks here in the flowchart now. If it cannot be clarified whether an intentional deviation from the label by the patient happens for therapeutic reasons or not, an appropriate LLT under PT intentional product use issue should be assigned. And if it cannot be clarified whether an unapproved product use by a HCP or patient consumer occurred by mistake or intentionally, an appropriate LLT under the PT product use issue should be assigned. These 2 are quite vague terms, but you'll find other more specific terms in MedDRA for dose or schedule deviations, which are also, so to speak, neutral, because they do not contain the information accidental or intentional. They can be chosen in combination with other MedDRA terms for intentional misuse, off-label use, or medication errors, and allow us to capture the details of what actually happened when no suitable combination term can be found in MedDRA. So in this screenshot from the MedDRA browser, you can see some of these neutral PTs, like extra dose administered, inappropriate schedule of product administration, incorrect dosage administered, incorrect dose administered, product administered to patient of inappropriate age, product administration interrupted, or product dose omission issue. Extra dose administered, inappropriate schedule, etc., etc. These do not contain the information whether this happened accidentally or intentionally. So they are neutral, so to say. You will find many of those. So any questions, Jane?
Yes, we've had a couple of questions, and I know you're going to cover this later, but you might just want to explain to people that it is coming later about off-label use and about if the information that it's off-label is contained, but we don't have the indication in the country-specific information, and it hasn't been explicitly reported as off-label. So I think a few of our attendees have got that question already.
Yes, so we will cover it with an example later on, so then we can discuss it.
Thank you.
And it may be more clear.
Thank you. Perfect.
Mm-hmm. So in order to search and select suitable MedDRA terms for verbatims that relate to unapproved product use, so deviations from the approved product information, the label, it is relevant to understand MedDRA structure and rules and the details of the PTC guidance documents, of course. But it is also important to make yourself familiar with the MSSO MedDRA browsing tools or your own in-house MedDRA browsers. I will now use the web-based browser that the MSSO provides to show you where to find the relevant terms and make you familiar with their hierarchy. So let me switch screens again. Here we are on the MedDRA website, and here you find a shortcut to the web-based browser. I can open it, log in, and here we are. So what you can see in the browser is, first of all, you have to look into injury, poisoning, and procedural complications. Here in the Explore window, let me make it more. And here you find the medication errors and other product use errors and issues, HLGT. And you see accidental exposures are grouped under this HLGT, and then the medication errors and issues, and they are sorted based on the stage where these errors or issues occur: administration, confusion, dispensing, monitoring, preparation, prescribing, selection, storage, transcribing. So and there's one NEC, not elsewhere classified, so a grouping that groups all PTs that do not fit into any of the other categories here. So the product use issue term, for instance, so this very vague term, here it is, product use issue. If you open it, you see there are many more specific LLTs underneath. So this very vague term you'll find in this NEC grouping. Now let us look into the administration errors and issues, HLT. So many PTs available here. You can see them. Make yourself familiar with those. If you are not fully clear about the meaning of certain PTs, what they're actually representing, then refer to the MedDRA concept descriptions, because sometimes you find very useful information here. You see already it starts with the definition of abuse and addiction here. Abuse for the purposes of term selection and analysis of MedDRA coded data. Abuse is the intentional, non-therapeutic use by a patient or consumer of a product, over the counter or prescription, doesn't matter, for a perceived reward, desired non-therapeutic effect, including but not limited to getting high. Abuse may occur with a single use, sporadic use, or persistent use of the product. So very detailed concept descriptions here, not really medical definitions, but explanations how these terms are used and interpreted in MedDRA. So what else do we have? For instance, dose and dosage. You see how granular MedDRA is. and that's why it's important to be really fully aware of the meaning of certain terms. Dose refers to a quantity to be administered at one time, such as a specific amount of medication, whereas dosage is more broad. It's the determination and regulation of the size, so the dose itself, the single dose, the frequency, and the number of doses, so the duration of treatment. It's much broader. Dose omission is explained here, and let us look into overdose as well. Here's the medication error definition that we saw before. The monitoring error, what is the monitoring error? Off-label use, also the definition for it. Overdose. For the purposes of term selection and analysis of MedDRA-coded data, overdose is more than the maximum recommended dose in quantity and or concentration. In other words, an excessive dose. And underdose, same, let us look for underdose. Here it is. Underdose is the administration of less than the minimum recommended dose in quantity and or concentration. You see, it's a number of explanations that are really helpful to better understand these terms, because as you can see here, MedDRA is very granular in this area, so it's worthwhile to look into this concept description in order to make yourself familiar with those. So this was the HLGT, product administration errors and issues, and this very vague NEC grouping. When we look into the SOC injury, poisoning, and procedural complications further down, we see off-label uses and intentional product misuses, use issues. So the intentional product misuses are grouped here, not too many PTs, but more specific LLTs underneath. Then here, the more vague intentional product use issue issues that can be used when you don't know whether an intentional deviation was for therapeutic purposes, yes or no. And the off-label uses are grouped here. Then we have another HLGT, overdoses and underdoses, NEC, not elsewhere classified. And we see here intentional overdose. An intentional overdose, why isn't it grouped here under intentional product use issues? Because an intentional overdose could also represent an off-label use. So that's why it's grouped under an NEC, more vague, not elsewhere classified, HLT, and the same holds true for the underdoses. Now, where to find these misuse we had abuse dependence terms. There we have to refer to the SOC psychiatric disorders and to the HLGT psychiatric disorders NEC. And here we have the HLT substance-related and addictive disorders with a lot of PTs again regarding alcohol abuse and tobacco dependence whatsoever, but also drug abuse and drug dependence. Very specific antepartum, postpartum as well. So here you find the relevant PTs for these concepts. Now let me switch back.
Caroline, we do have some questions.
Oh, yeah.
But do you have examples of use in unapproved age group if the intention is not clear?
If the intent is not clear, so it really depends whether you have the information whether it was accidental or intentional. First, if we don't know that whether it was intentional or accidental, then I would refer to a more vague term, and we would go to our medication error term here, NEC, and under product use issue, you see drug use in unapproved age group. Here it is. Okay.
Yeah, and when you're in the browser, could you show once more where we can find the descriptions, the concept description?
Yeah. On the top, you see the header here, MedDRA concept descriptions. You just click on it and then this window will open and you will see the concept descriptions in alphabetical order. You can either scroll down as I did in order to look at all of them, or you can really click on the respective part if you know that you would like to see the concept description of off-label use or overdose, for instance.
Okay, thank you very much. I'm just working through these. The off-label use questions, I'll save all of those for later. So if anyone's got off-label use questions, just hold on to them. I think that's all for now, Caroline.
Okay, so let me switch back then to the presentation and continue. Here's again the browser, the concept description, where to find them, and the hierarchy that I've shown you in the browser that is relevant for our topic today. Now, what kind of terms can we find under HLGT medication errors and other product use errors and problems? We can find PTs for certain types of errors, such as wrong drug, wrong patients, wrong route. They can be selected together with, for example, PT prescribing error or LLT prescribing error if no combination term is available. So they are specific for the type of deviation, but they do not contain any information about the stage where this specific error occurred. Then we have terms that link an error to a stage in the medication use process, such as the prescribing stage. In addition, there are terms for intercepted errors, prevented by third-party intervention so that they didn't reach the patient. And here you see an example, intercepted product prescribing error. MedDRA also contains two PTs that describe the possibility of an error or signal a circumstance that could potentially lead to a medical device use error or medication error. And I will provide more examples later on, as well as the vague PTs that I've already addressed, which can be used when it is unclear whether the reported incident was due to an error or happened intentionally, or when it is unclear whether an intentional deviation from the label by the patient or consumer occurred in the context of therapeutic use. So product use issue and PT, intentional product use issue, are these PTs. Now, next poll question for you. We have a report on a dose taken was below the minimum recommended dose in the product label. So the patient took a dose and we know that it was below the minimum recommended dose in the product label. Try to recall what I've shown you in the concept description. How would you code this verbatim? Underdose, drug administration error, accidental underdose, or incorrect dosage administered. Let's check. Most of you have gone for underdose. Let me close the poll here. And of course, we heard before that an underdose is the dose below the minimum recommended dose in the product label. So underdose is really the correct assignment here. Well done. Drug administration error, we don't know. We have no idea whether this occurred accidentally or intentionally. So that's why we cannot assume that an error occurred here. Same holds true for accidental underdose. So this would be more specific than drug administration error. It would contain the information underdose, and this is correct. But we don't know whether this was accidental. It is not reported. We don't have this information. It could also have been an intentional underdose. And incorrect dosage administered, yes, it was administered, but as I've shown you earlier, dosage is a more broad term. So it not only includes the single dose, but it includes the schedule and the duration of treatment as well. So We are talking about the dose, not the dosage. Next one. Inadvertently took excessive dose of the prescribed pills. Again, remember the concept description that I've shown you before. And when you look at these options here, which one would you select? Incorrect dose administered, overdose, accidental dose increase, accidental overdose. Let's see what you're going for. Well, we are told that the excessive dose was taken inadvertently, accidentally, but is it an accidental overdose or is it an accidental dose increase? Again, remember the concept description. And the concept description said overdose is more than the maximum recommended dose in quantity and or concentration, i.e. an excessive dose. And this is exactly what has been reported here. Now let me close the poll. And most of you are on the right path here. So we are looking at an accidental overdose here. We know it was accidental. It happened inadvertently, unintentionally. And the wording clearly refers to an overdose based on the concept description. Any questions that relate to these exercises, Jane?
No, we've had all the questions about off-label use, and we've had one question which you might want to build into your coming, Carol-Ann, coming slides. Could you address how the wording of self-medication, what that would mean when we think about the concepts? What does self?
Okay. Yeah.
Okay, so that just those, and then off-label. Thank you.
Mm-hmm. Yep. Now, then let's continue. And now that we have made ourselves familiar with the classification of medication errors and other types of product use issues, let's have a look at some general principles for coding of medication errors. Just a short reminder before starting regarding the basic rules to be followed for coding with MedDRA. The quality, of course, of the reported information and the extraction of relevant information during data entry are a basic requirement for good and meaningful coding. If the information received is vague or ambiguous, of poor quality, then ask for clarification. Coding is done at the LLT level, and the LLT that most accurately, most specifically reflects the reported incidents and events should always be selected. Nothing should be interpreted, added, and no relevant information should be omitted. This is really the basic MedDRA coding rule, code as reported. And of course, only current LLTs should be used for coding. I assume you are all very familiar with these basic rules, so I will not go into these any further. For coding product use errors and problems, the following tips may be helpful. First and foremost, you should be familiar with the MedDRA concept descriptions and the PTC guidances so that you know where to find more detailed information, more guidance to achieve accurate and also consistent coding. You should also have good knowledge of the MedDRA structure and hierarchy, particularly in SOC injury, poisoning, and procedural complications. Once you have found a potentially appropriate LLT and PT for the reported incident, check if the placement of the selected LLT and PT accurately reflects the reported event, whether all the information that is contained in the verbatim is really reflected by the hierarchy as well. It is best to search the MedDRA hierarchy top-down when coding medication errors and other product use concepts, unless you are already very experienced in coding such incidents. And finally, if you can't find a specific term for medicines, vaccines, or medical devices, look out for a product term that would be suitable for your coding tasks. So to look out for a more vague term that does not specify the specific medicinal product, but that would specify the specific deviation from the label. The companion document specifies some principles for coding medication and other product use errors. When to use the PT medication error, when to select more than one term, when to use the PT off-label use, how to capture potential and intercepted medication errors, how to capture both the specific type of error and the stage of the medication use system where the error occurred, when to capture the root cause for medication errors, and that we should not infer a medication error. And I will address them one by one. The first principle refers to the use of PT medication error. As coders, we should not use this term unless we have no further information reported in the case. If you have further information, then search the hierarchy under HLGT medication errors and other product use errors and issues, and select the most specific LLT that you can find. And if a specific error is reported, but no suitable term can be found, then please submit a change request to get a better term, and assign the LLT that represents the best, so to say, approximation to the reported incident as a placeholder. And here an example, if it is only reported that the patient inadvertently didn't use the medication as prescribed and no further information is available, then of course LLT medication error can be selected, which is grouped under the same PT medication error. We know it's accidental, the patient didn't use the medication as prescribed, and no further information is available. So the only option that we have here in order to at least capture the basic concept is medication error. Sometimes you will get a report of a chain of events where an initial error leads to additional subsequent errors or even adverse events in the patient. Then code the initial error as the priority, and all subsequent errors and adverse events have to be coded in addition, if they were reported, of course. But do not use multiple LLTs to represent one singular incident that is reported with both a general and a more specific description in the reported term, the verbatim. So this is in line with a general rule for coding of combination terms that refer to a general medicinal disorder that is further specified. As an example, if an arrhythmia is reported that is specified as atrial fibrillation in the given verbatim, one would only code the atrial fibrillation and not code arrhythmia, cardiac arrhythmia in addition. And the same holds true for the medication errors and medication issues. So if you have a specific information, use this specific information for coding purposes. Again, an example for this principle, it is reported that a nurse miscalculated the dose and the patient received 40 milligram instead of 20 milligram of his medication. He experienced severe hypotension. So what do we have here? We would capture the initial error with the LLT dose calculation error, same PT, plus the subsequent administration error, because there was a dose calculation error that then led to an administration error. So this needs to be captured. With the LLT incorrect dose administered, PT is the same, and of course also the resulting adverse event in the patient, the hypotension. So this is a chain of events starting with the dose calculation error, leading to an administration of an incorrect dose, and finally to an adverse reaction in the patient, a hypotension. And everything needs to be captured, of course, by coding. Do we have questions for these two first principles, Jane?
No, not on these principles, Caroline.
Okay.
Not on these principles, no.
So then now we come to the area that really causes a lot of questions currently. So the next principle refers to off-label use. Always consider the criteria and information required to select a term under PT off-label use. Off-label use relates to situations where a healthcare professional intentionally prescribes, dispenses, or recommends a product for a medical purpose, not in accordance with the authorized product information. It has to be an HCP, it has to be intentional, and for a medical purpose in the context of therapeutic use. These are the three main criteria that must be met for high-level classification. The highlighted sentence added in the latest version of the MedDRA term selection points to consider document is copied from the points to consider companion document, release 2.0 from 2020. So both documents are consistent in this regard. As a coder, off-label use terms should only be selected when off-label use is specifically mentioned in the reported verbatim information in the case. Coders should not take this decision when only the three criteria are met, because it needs more specific product knowledge first and information about the country of origin of the reported case. And local regulations and the product information may differ between regulatory regions. So encoders do not have access to, usually do not have access to this information, where origin of the case, how the label looks in the respective country, etc. So regulators are very clear on this. You'll see that in the points to consider documents, there is no example for off-label use where off-label use is not clearly named in the wording. How to achieve this? If the coders code out of context, while this really is in responsibility of the local pharmacovigilance units then of a respective pharmaceutical company, because they are well aware of the local label, of course, for the products. So they have to add this information to the cases. And then in term extraction for coding purposes during case processing, this information needs to be captured in the verbatim. Only then the coders can really classify as off-label use, because otherwise they do not have the information whether this intentional deviation by the HCP for medicinal purposes was deviating from the local label. Coders do not have access to this information, usually. If you're working for a smaller company with only few products, and you are well aware about the label, the local labels, and you have access to the information that of where the case comes from, where it was originally captured in the database, then of course it may be a different story, but it really depends on your processes. So let us look at an example here. It is reported that a pediatrician decided to use COVID-19 vaccine off-label for his 10-year-old high-risk patient, although not yet approved for this age group. And does this verbatim now fulfill the criteria for classification as off-label use? And is off-label use explicitly mentioned? So an HCP has caused the deviation. It was a pediatrician. He did it intentionally. He decided to do so, and based on therapeutic considerations. He wanted to protect his 10-year-old patients from an infection. And we are told that he decided to use the COVID-19 vaccine off-label, meaning that the vaccine is approved for immunization against COVID-19 infection in the respective country, but not for this age group. So the most specific LLT for this scenario is off-label use in unapproved age group under PT off-label use. So I hope with these explanations, the handling of coding to off-label use is more clear now. So it's really about access to information about origin of the case, country of origin, and access and knowledge about the details of the local label. This is really the key point here. And this is something that mostly coders do not have access to, and that is why coders should not take the decision whether a reported event, even though that when the three criteria, the main criteria are met, whether this is really representing an off-label use, yes or no.
Okay, Caroline, so we've had the question, what if the coder has access to the local SMPC? Is it then correct to code off-label use? Debulla's asking.
If you know the origin of the case and you have clear access to the label, and this is also described in your data entry conventions and maybe also in your internal coding conventions, I think then if this is the case, you have the full information about what is whether something represents off-label use, yes or no. But I would really try to document this very clearly to show that the coder has access to this information and is capable of, based on education, training measures, is capable of taking this decision.
And we've had a number of questions around this, so I think you've covered it clearly, but we've still got some other questions. If the coder is a physician and has all three criteria for off-label use, but off-label is not mentioned in the narrative, that still counts, doesn't it, Caroline? We still can't code off-label use?
No, because even if it's a physician, he needs to have the full information, as I mentioned, country of origin of the case, all the details of the local label, whether the product is registered, is approved for use in the respective country at all, for which indication it is approved, and whether the label would cover what is reported there. So it's really quite a complex decision that you have to take there.
And we had the question of when you have a situation like you had in the earlier example with Lisa, that the drug was intentionally prescribed by the physician, but what would you code it to is the other question we've had. I think you might have mentioned this one already. If not, you're coming to
yes.
it.
So if you get such a report and you don't know the country of origin, as I mentioned, and the local label, then it will, and you don't have the information that it was really off-label use by the local PV unit or in the respective verbatim, then you wouldn't be able to classify as off-label use. You need this additional information.
So is it drug use in unapproved indication was one of the questions we had, if the indication was different?
It would be, if you know it was an intentional deviation, then it would be intentional deviation from intentional administration or prescription for an unapproved indication. Yes.
That's it.
But we would not be, but we would not be capable of really taking the decision that this represents off-label use.
Okay, thank you, Caroline. So I think I'll say if anyone's got remaining questions now, send them again, because I think you've addressed all that we've received so far.
Mm-hmm.
Thank you.
Welcome. So principle number 4 refers to potential medication errors. And I mentioned this when showing the different types of terms that we can find for medication errors and other product use errors issues in MedDRA. So such incidents should also be captured, and MedDRA has 2 PTs for doing so. First of all, LLT and PT circumstance or information capable of leading to medication error, and LLT and PT circumstance or information capable of leading to device use error. And MedDRA terms that help capturing the contributing factors that should also be selected, like for instance, LLT drug label lookalike. Why do some regulators want to receive this information, are actually quite keen to receive such information? Well, in such scenarios, no medication error happened yet. but could of course occur in the near future based on the reported contributing factors, like drug name confusion, drug labeling confusion, whatsoever. When understanding the background for these potential errors, regulators could take steps to prevent errors even before happening. So depending on your local requirements, do not omit such information, but capture all relevant information when receiving similar verbatims. Encode both the potential for an error by selecting one of these PTs here, and also code the contributing factor or factors. Again, an example for this principle, the pharmacist reported that the blurred print on the drug label could lead to the wrong dose being given. No medication error occurred yet, but the pharmacist saw the circumstance, the blurred print on the label, that could lead to errors in the future. So remember, we would code the potential error by selecting LLT circumstance or information capable of leading to medication error, same PT, and we would also code the scenario, the root cause that could lead to a medication error. Here, the blurred print on the label by selecting LLT product label text illegible under PT product label issue. Be aware that we would not code the type of potential medication error in addition by assigning LLT wrong dose. That would convey that a medication error actually happened, and here only the potential for a medication error is reported together with the root cause, and this needs to be captured. Next principle. Sometimes medication errors at an earlier stage of the medication use process are prevented from reaching the patient. So a medication error occurred during prescription, preparation of the medication, etc., but is detected and intercepted by an active intervention of an additional person. When such scenarios are reported, the selected term for the intercepted error should represent the stage where the error actually occurred, not where it was prevented. Meaning that when it is reported that a pharmacist dispensed the wrong drug, but the nurse identified the error before giving it to the patient, we should select LLT intercepted drug dispensing error under PT intercepted product dispensing error, capturing the stage where the error actually occurred. We would not code to LLT intercepted administration error because the nurse did nothing wrong. The error occurred at the dispensing stage, and this needs to be captured. Further questions for these two principles that I've just addressed?
I'm going back to some of the other questions, Caroline. Are the guidelines around coding of medication errors, do they apply for devices? I've said yes.
Yes, for all medicinal products. But again, it depends on local regulations as well. So we as an MSSO, we cannot state general rules because it really depends on the local regulations of the respective countries.
And then if you have a vaccine and you have off-label use in an unapproved age group for the vaccine, you don't also need to code off-label vaccine use, do you? Because the vaccine's captured in the case. So
the vaccine is captured in the case. Yeah.
So that one. If a healthcare professional prescribes a medication for an indication and the patient takes it for a different indication, it's not off-label use. So does that capture, would that be a medication error, or would that be misuse? The patient taking it for a different indication.
So when the patient is prescribed a drug for a specific indication by his doctor and decides to take it for a different indication, then it is a misuse. Yeah, it's if it's a conscious decision. When it's an accident, then of course it would represent a medication error. If it's a conscious decision for therapeutic purposes, because the patient thinks that he can take this drug, somebody has told him that this may be helpful for another indication, and takes it because he believes in it and just would like to try. So it's a conscious decision, then it would represent a drug misuse.
If you have if you have a report where it says the drug will be administered for this indication, and the indication's not approved, and you don't know if it's actually been administered yet, what would this constitute?
So if you have the information that it was off-label and it was triggered by the doctor for therapeutic reasons, then it would be off-label use, yeah, independent of the fact whether it was finally administered, yes or no.
But here we don't know, so we can't do anything unless we know.
No.
So if it's been, does that even need to be entered into a database, was the question. If you have, for example, the medication will be administered during the journey for this indication, and it's an unapproved medication, it hasn't been administered. So if we don't know it's off-label use, is that correct, Caroline? If we don't know it's off-label, then we can't do anything with it. No.
If it's if you don't know it, off-label use is really a difficult topic. So keep in mind the decision chart for all the other concepts, and you will be able to really classify this appropriately. And for off-label use, you have to be cautious because of the reasons that I described in detail before, because we have the problem there that coders usually do not have access to the information where the case was originally reported, and they do not have access and knowledge about the local label and whether the drug is approved in the country at all.
That's all our questions for now. Thank you, Caroline.
Mm-hmm. Okay, we already talked about the stages of the medication use system when looking into the HLGT medication errors and other product use errors and issues, and the MedDRA hierarchy underneath. So this slide now shows the different stages, starting with the storage of the medication, prescribing stage, and then the transcribing stage, prescribing, preparation, dispensing, administration stage, and finally the monitoring stage. One of the principal MedDRA coding rules: code as specifically as possible, capturing the full information of what has been reported, also applies to coding of medication errors, of course, meaning that if a specific error is reported that occurred at a specific stage of the medication use process, we should capture, of course, the full information, the type of error, and the stage where this error occurred. So you'll see that MedDRA contains many terms that capture both the type of error and the stage, like for instance, LLT, wrong drug prescribed. Others only capture the type of error, like for instance, LLT, wrong drug, or LLT, wrong dose. So if the stage where the error occurred is unknown, you can just select the LLT for the type of error. And others capture the stage only, like drug prescribing error or drug dispensing error. Again, if the error is not specified, you would just select an LLT to capture the stage where the error occurred. So always capture both the stage and the type of error when it is known, and if the stage is not known, capture the type of error only. If the type of error is unknown, just capture the stage. When both the stage and the type of error are reported, you would look for a combination term in MedDRA and use a single LLT to capture the full information when possible, as shown in the first example here. When it is reported that the pharmacy dispensed the wrong drug, the LLT wrong drug dispensed would capture the full information. There is no need to assign two codes like LLT wrong drug, and LLT drug dispensing error. But sometimes you may not find a suitable combination term. If it is reported that a doctor mistakenly prescribed the wrong strength, you would have to split to capture the reported information in full by assigning wrong strength and drug prescribing error in this instance. So always try to capture the full information. We already shortly addressed the root causes when talking about potential medication errors. And if a medication error is reported in conjunction with the actual cause of this error, then always select a term for the root cause plus the resulting error. Remember what we discussed earlier. Root causes are critical to understand why an error occurred and to identify interventions, measures that can be undertaken to prevent the error. And that is why many regulators are very interested in obtaining information about these root causes. The next example describes such a case. So a doctor wrote a prescription for 40 milligrams of drug X for angina pectoris, every 6 hours. But because of the illegibility of the prescription, as you can see on the slide here, the nurse administered the same dose of drug Y, a calcium channel blocker used in the treatment of hypertension, for which the maximum daily dose is only 10 milligrams. So because of this error made, the patient received 160 milligrams of this calcium channel blocker per day, 4 times 40 milligrams. And remember, the maximum daily dose is only 10 milligrams for this product. And a day after taking the first 4 overdoses of the calcium channel blocker, the patient suffered a heart attack and died. So what needs to be captured here? The indication for use, angina pectoris, it may be recorded in the medical history of the patient, and the actual incidence that, so first of all, the root cause, the written prescription illegible. There is an LLT for this root cause, the resulting medication errors, the administration of the wrong drug, and of course the accidental overdose, and the resulting adverse reaction in the patient, the heart attack. So remember, it is very important to capture the root cause and all information that is provided in this case. So it would not be sufficient to just only code LLT wrong drug administered, but you would also need to, of course, capture the accidental overdose in this instance. So do we have questions for these 2 principles?
No further questions, Caroline.
Okay. So, and the next slide now shows the last principle that we will discuss today. Do not infer a medication error. Remember another basic rule for coding with MedDRA. Code as reported. Do not add or subtract relevant medical information. The same rule also applies to the coding of medication errors, of course. If you receive a verbatim that describes a deviation from the label, an unauthorized use of a product, only select an LLT or LLTs that reflect what has been reported. Do not assume that a medication or device use error occurred if this is not made clear in the verbatim. So if it is reported that a nurse administered 50 milligrams of drug X, for instance, do not assume that this represents a medication error. Try to obtain more information from the reporter or find out the dose range referencing the prescribing information of the respective drug. So with this, here just a nice summary, a nice visual presentation of the different types of medication error cases taken from the good practice guide of the European Medicines Agency. In the first example, a medication error occurs, here it is, leading to an administration error, so it reaches the patient, and to harm in the patient. So a case with an error, medication error, with a subsequent adverse drug reaction in the patient. Next, an error happens and reaches the patient, here it is, but it does not result in any harm to the patient. Next, the third type of report refers to an intercepted medication error, where an error occurs in the medication use process, but it is prevented from reaching the patient or consumer. It's an intercepted error. And finally, a potential error is described, where it is reported that there is a risk for a medication error in the product use process due to special circumstances, a special root cause like drug name confusion or drug packaging confusion or drug appearance confusion. So no error occurred yet. It didn't, of course, not reach the patient. So this is a potential error. In the last part of the webinar, we will work together on 5 examples to apply the previously introduced decision chart and the general principles for coding medication errors.
So, Caroline, we've got a couple of questions on the examples before we move on to the next section.
Okay.
So the one with the nurse prescribing it, could we look at that one again, just to explain why it was an accidental use when the nurse prescribed it, when it was not legible?
Where was it?
That's all.
Here.
That one.
Mm-hmm.
Why accidental? The nurse prescribed it when it was not that one. So
the doctor did nothing wrong. He wrote a prescription for 40 milligrams of drug X for angina pectoris every 6 hours. But the prescription was illegible. And the nurse then, instead of asking him, what does it really mean? Do I interpret it correctly? She just took it and interpreted and administered the same dose of drug Y. So she did something wrong. This was definitely not intentional, because it was not just an overdose, it was an immense overdose in this case. She wasn't able to really identify the drug, and she saw the dose, yes, but she was not able to see or clearly read the drug that was prescribed in this instance. So this is clearly representing an accidental deviation from the prescription. And the root cause was, of course, the illegibility of the prescription.
There's also, I'm just responding here, that could you just address that we don't code death in that example, because we know the cause?
Yes, yes, of course, because the outcome of the heart attack is, of course, captured elsewhere. It's a serious incident, and it's fatal. So it's captured in separate database fields, the outcome. So it doesn't need to be captured with MedDRA. You would only use outcome terms like hospitalization or death when no further information becomes available, or when more information is contained, like acute cardiac death or so. Then more information is contained in the respective LLT, but you wouldn't code just death if you have a reason for the fatal outcome that you can code.
So we've had some follow-ups on that. Is there a term for a fatal heart attack? There isn't a MedDRA term for fatal heart attack, is there? It's just...
No, there's no, because as I said, the outcome, the fatality can be captured in a separate database field.
Would you then have a reaction of death? Would you capture it in a separate field? You've answered that one.
Yeah, no.
And is it a necessary requirement of a study to capture medication error as an AE, or does it depend on regulatory requirements?
It always depends on regulatory requirements.
And the final one I've just come to, in this one with the nurse, there isn't the information that it was not intentional in the, I mean, you know, because of the eligibility means it was not intentional.
Yeah,
that's where we...
Eligible. She should have asked, she didn't do so.
That's why we've taken it that it was unintentional, that it was an accident. Do we need to code the angina pectoris because it will be covered by the indication?
Yeah, either by the indication or medical history of the patient, depends on the narrative actually, but somewhere you would capture the angina pectoris.
The angina would be the indication, or somewhere else it would be in this, but we've just put it for completeness. That's everything that we've had so far, Caroline. We've had quite a few, but that's everything covered.
Okay.
Thank you.
Okay, then let's start here. At first, you will have to assess the reported information. So first check always, if you have such a report, the 3 criteria for this classification. Did the incident occur intentionally or unintentionally? Who has caused it? Who triggered it? Was there a therapeutic purpose? Then check at which stage the error occurred, whether this was reported, and whether it led to subsequent errors and even harm in the patient. If contributing factors are reported, they need to be captured in addition. And or was the report referring to circumstances that could lead to a medication error? This needs to be considered as well and can be coded. Or was the error intercepted before reaching the patient? So all this information, the type of report will really influence the way you search for appropriate terms in MedDRA. It will help you find the most suitable LLTs, the closest matches. Always try to cover all the reported information and then look for suitable terms in MedDRA. Here our first example. It is reported that the nurse forgot to administer the second of 2 chemotherapy treatments to the patient. So what can we take from this report? It is reported. Is it reported whether it was accidental or intentional? Yes, we know that the incident happened accidentally. The nurse forgot. Do we know what caused it? Yes, an HCP, a nurse. And was it in the framework of therapeutic use of the product? Yes, it was. We also know the stage where the error occurred, but no root cause was provided. So how would you approach this report? Which LLT would you select here? Scheduled daily dosing taken less frequently, drug dose omission in error, drug use for unapproved schedule, or temporary interruption of therapy. What would you select here? Look at the verbatim, try to capture as much of the information as possible with a specific term for it. Yes, I see that we have a preference here. Let me close the poll. So we have clear preference for drug dose omission in error, and this is of course fully right. We know the nurse forgot, so it was accidental. It was just 1 dose that was missed because of this error by the nurse. So it's a drug dose omission in error. Drug dose omission refers to 1 dose. A scheduled term, scheduled daily dosing taken less frequently, would only be used when this dose omission occurs in a regularly. Same is true for drug use for unapproved schedule. And temporary interruption of therapy, I will come to this in a minute. So let us first use our decision chart here. We know that the incident occurred in error. We know that it was caused by the nurse and HCP. And we know that it occurred in the framework of therapeutic use. So the incident has to be classified as medication error. Now let's have a look into the MedDRA browser here. Let me switch screen again and look for the terms that were suggested, proposed in the poll. So when I look into SOC injury again, I know it was an administration error, so then we would look into the product administration errors and issues HLT here. And you see it's a lot of options that we have here. So product dose omission in error would be the correct term. There's no accidental use of training device instead of active product, drug dose omission in error, forgot to take the product, missed dose in error, product dose omission in error. So drug dose omission in error would be the most specific term to select for the reported incident here. You see that there's also a vague term available. When you don't know whether something occurred intentionally or accidentally, you can use product dose omission issue that you can see here underneath. As I mentioned earlier, inappropriate schedule, where is it? Inappropriate schedule of product administration. Here, drug dose administration interval too long, too short, 1 monthly dose taken less frequently, etc., etc. All these LLTs would be selected when it is reported that dose omissions occur regularly, take place more often, like when a patient takes a once daily dose less frequently. And LLT, drug use for unapproved schedule, is grouped under product use issue, drug use for unapproved schedule. Here it is. So this PT is of course much too vague for the reported scenario. We know that this was an accidental deviation by the nurse. So it was an accidental dose omission. Now, what about the last option in the poll, therapy interruption? So therapy interruption, let us search for it in the search window. Therapy, search. Here we are, temporary interruption of therapy. Right mouse click, go to browser, and you see that this term is grouped in the surgical SOC. Here it is, therapy interrupted with the LLTs, therapy interrupted and temporary interruption of therapy. LLTs under this PT should only be used when a therapy was interrupted due to reasons that are out of the control of the HCP or patient consumer, like supply, insurance, or financial issues, for instance, or product availability issues, when a patient cannot afford the medication. Then you would select one of these LLTs. Now let me switch back. This is just a reminder of what we just saw. Here the correct assignment would be drug dose omission in error. And you can see the hierarchy of the other proposed LLTs of the poll in the screenshots. So the correct term selection would be drug dose omission in error under PT product dose omission in error. And most of you voted for this term, so well done. Any questions, Jane?
No, I think I've addressed them all, Carol-Ann. So if there's one question about, I don't know if you can take this one off, it's out of scope. If the medication error leads to a serious adverse event, is the medication error and the adverse event both considered to be serious?
That's a very specific, I would need to, it really depends on your own data entry conventions in pharmacovigilance, and I would have to look into regulatory guidance myself here in order to classify, to answer this question.
So both would.
So the adverse event, of course, is a serious one, but whether the whole case is a serious one. So the medication error may not be serious, but if it led to a serious event, it depends really on your data entry conventions for your drug safety database.
Yes, thank you. It's not really in scope. Thank you, Carol-Ann.
No.
Thank you. That's all.
Okay, next one. Here it is reported that a patient did not read instructions thoroughly enough and took drug X for prophylaxis instead of treatment of the approved indication. So what do we know based on this information here? Is it reported whether it was accidental or intentional? Yes, we know that the incident happened accidentally. The patient did not read the instructions thoroughly enough. he was not intending to deviate and harm himself, but he did not read the instructions thoroughly enough. Maybe he had sight problems with his sight, or he was distracted, whatsoever. We don't know. We know that the patient caused the incident. We know it was in the framework of therapeutic use, and we know the stage in the medication practice where the incident occurred. But again, no root cause was provided. So your turn again. Patient did not read instructions thoroughly and took drug X for prophylaxis instead of treatment of the approved indication. So which LRT would you select here? Drug use for unapproved indication, unintentional use for unapproved indication, product leaflet instructions confusion, off-label use in unapproved indication, or drug administration error. Maybe split coding is necessary here. What would you do? Let's have a look. Drug use for unapproved indication, unintentional use for unapproved indication is the main vote here. Product leaflet instruction confusion we also have, and drug administration error. Some of you of off-label use, remember, always triggered by HCP, so this is not correct. And yeah, no vote for it. Very good to see. So let me close the poll here, and let us again use our decision chart first. So we know that the incident happened accidentally. We know that it was caused by the patient, and we know that it was in the context of therapeutic use of the product, so meaning that this verbatim describes a medication error. So let me now search for the more specific terms in the browser again. To switch, here we are, and I will collapse everything so that we have a nice new screen, and I will use the search field in this instance, and we know that the product was used for administered for an unapproved indication. So let's see whether we find an LRT for contraindicated drug administered, contraindicated drug combination. No, this was not reported. We don't know whether this was contraindicated. So there is no suggestion, there is no LRT that would contain this information, administration, and the fact that it was for an incorrect indication. So let us look for use and indication instead of administration. And here we have quite a number of suggestions from the browser. Device use, drug use for unapproved indication. So that is one option. We also have the unintentional use for unapproved indication. So we said it's an accidental incident. Unintentional use for unapproved indication would capture the accidental nature of the incident and the specifics, so that it was for an unapproved indication. So drug use for unapproved indication would also be an option. Let's keep these two in our mind here. But with either of those, we would not capture the fact that the drug was finally administered. So that's why we have to split code in this instance. It is necessary to split code to capture the full information, and that's why drug administration error would need to be selected in addition. So drug administration error, because we have no suitable combination term for a drug administration error because of unapproved indication. So drug administration error would need to be selected as well. So off-label use and unapproved indication, I explained this already, would be incorrect because the verbatim does not describe an off-label use. Is something that was triggered by the patient. And what about product leaflet instructions confusion? So when I look into injury poisoning here, we have the medication errors again, and here we have the product confusion terms under HLT, product confusion errors and issues. And you see we have product appearance confusion, design, dosage, dose, label, name, packaging confusion, very specific terms. Product label confusion is available, here it is. So drug label, lookalike confusion, expiration date format confusion, patient instructions for use in label confusing. Would this be suitable? So this would not reflect what has been reported actually. The patient didn't read the instructions thoroughly. It was not reported that the instructions themselves were confusing. So this needs to be clearly distinguished. So it was something that was triggered by the patient and not by the label. So nothing was wrong with the label. This was not reported. Now let me switch back. And here we have our terms. Product leaflet instructions confusion, we talked about it, off-label use would be incorrect. We would need to capture that the drug was finally administered via LLT drug administration error. And then we have the two options, drug use for unapproved indication or unintentional use for unapproved indication. Both would be suitable because they capture the fact that the error occurred, the specifics of the drug administration error, that it was for an unapproved indication. One of them also captures the accidental nature, but we capture the accidental nature with the LLT drug administration error already. So both would be suitable in my view, but I would always prefer to really assign the most specific one. So my preference would be to code both unintentional use for unapproved indication and drug administration error.
So
here we are.
The question, yeah? This one, Caroline, when you explain it, is that can you talk about use and the fact that use includes administration, so why you've selected the two?
Use does not include administration, and that's why I would split code here. So I would split code and capture the fact that the error really reached the patient via drug administration error. And then we have to capture the specifics of the drug administration error, that it was for an unapproved indication. And the question was whether we would select unintentional use for unapproved indication or drug use for unapproved indication. And my preference would be to split code and code both unintentional use for unapproved indication and drug administration error. To capture, remember what I said, you all should capture the stage where the error occurred and the specifics of the error. And we cannot find a suitable combination term for an error, administration error, for an unapproved indication, and that's why we have to split code here.
So you're saying use is more general, administration is more specific to what actually, yes, the fact it reaches.
Yeah, exactly.
Use is broader. Then we've had another comment that explain it. Can you explain about the root cause and capturing the root cause?
We will have an example with root cause later on in the webinar, so then we can discuss this.
Okay.
So here we have the final suggestions. We would select drug administration error under product administration error and unintentional use for unapproved indication. Same PT in order to capture the specifics of the product administration error. Further questions, Jane?
Yeah, just about use again. Why do we have administration error as well? Because it's told it's use, but that same question.
Yeah, use could be anything. Use could be that it was used on the dispensing stage for an unapproved indication. So you should really capture the fact that it led to an administration error in this instance. Capture the stage where the error occurred. It was at the administration stage for an unapproved indication. And use is more general. Use is could relate to any stage of the medication use process.
That's fine. Thank you, Caroline.
Yeah. Next one, patient took more than the prescribed dose to get a better drug effect. So let's look at this verbatim and answer the relevant questions here. Is it reported whether it was accidental or intentional? Yes, we know that the patient consciously decided to take more than the recommended dose to get a better drug effect. Do we know who caused it? Yes, it was a decision of the patient. And was it in the framework of therapeutic use for therapeutic purposes? Yes, it was. We also know the stage where the error occurred, but again, no root cause was provided. So again, your turn. Patient took more than the prescribed dose to get a better drug effect. Would you select LLT unapproved dose administered, intentional overdose, wrong dose administered, intentional misuse by dose change, or incorrect dosage administered? What would you do? Let's see what you're leaning toward. Unapproved dose administered, intentional overdose. So most of you are going for intentional misuse by dose change. Some of you are also considering intentional overdose or incorrect dosage. But remember, dosage is a broad term, does not only refer to the dose, but also to schedule and duration. So let me close the poll. We have the intentional overdose and intentional misuse by dose change. These are the main answers here. Wrong dose administered does not capture the fact that it was really intentional because the patient took more than the prescribed dose to get a better drug effect. So it was an intentional decision to get a better drug effect. So we need to capture the fact that it was intentional. And both options, intentional overdose or intentional misuse by dose change. So first, let's us look into our decision chart as well. Here we have a different scenario. We know that it was intentional. We know that it was caused by the patient. And we know that it was for therapeutic purposes. So meaning that this verbatim describes an intentional drug misuse, an intentional product misuse. Now let me check for the terms that we had here. If I go again to my injury SOC here, you know that we have here the HLGT off-label uses and intentional product misuses use issues. And we saw that this is clearly product misuse by the patients. So an intentional product misuse. Here we have the HLT for the intentional product misuses and intentional product misuse, device misuse, misuse of drug delivery system. So this is a PT to look at. And here we have some more specific LLTs, and under these we find intentional misuse by dose change. It's not dosing frequency, it's not product use duration, it's intentional misuse by dose change. Here we are. So this would be the appropriate LLTs to select, and most of you have voted for them. Again, well done. So first classify the actual deviation and then look for the respective most suitable LLT. The other option that we had was intentional overdose. So intentional overdose, you find here overdoses. Here we have the overdoses. You would find here it's overdoses NEC. So this would not reflect a misuse. You would not capture the fact that this was actually a drug misuse. So our verbatim alone does not allow for classification of intentional overdose either, because we are only told that the patient took more than the prescribed dose to get a better drug effect. We don't know whether it's still in the margin, the dose range that is defined by the label. We only know that the patient took a bit more than was actually prescribed. It could still have been in the respective label, covered by the respective label. So that's why a classification as overdose would be incorrect. And all the other options that were offered in the quiz were incorrect. LRT's unapproved dose administered, incorrect dose administered, and incorrect dosage administered do not represent intentional drug misuse, just drug administration errors or use issues. So let me switch back. Here again, the LRTs that were suggested in the poll, and here is the correct assignment. We would need to classify as misuse. That's of course the main classification that we need to consider, and then look for the most specific LLT that is available for the condition. And as mentioned already, we cannot assume an overdose here, could still have been in the approved dose range, and all the other terms represent errors and issues, so would not represent a drug misuse as reported in our verbatim. So here is the final suggestion: LLT intentional misuse by dose change under PT intentional product misuse.
We've had
we have questions.
Yeah, we've had a couple of questions here, both of them asking, should we capture the to get a better drug effect as an indication or some underlying, or the fact that they did get a better drug effect, if we know that?
Yeah, no, I wouldn't, to be honest. Yeah, so it's a misuse, that's the main purpose. If they get a better drug effect, it really depends on the coding scenario. So you would need more information in order to capture something like unexpected therapeutic benefit or something like that. But I think this would be an overkill.
Yes, I agree. Because if you coded drug effect increased, well, that's not really reflective because they've taken a bigger dose. So it's not reflective of the standard use. So I wouldn't code that either, Caroline.
No.
Thank you.
Okay, next one. I have to speed up a little bit to not overrun here. Doctor prescribed drug A off-label for suppression of preterm labor after a careful risk-benefit assessment. So what do we have here? Was it accidental or intentional? We know that. It was after careful risk-benefit assessment, so definitely intentional. Who has caused the incident? The doctor. Was it for therapeutic purpose? Yes, it was. At which stage? It was prescribing stage, and no root cause was provided here. So what would you do with this one? Would you assign drug use for unapproved indication, or drug prescribing error, or drug prescribed for unapproved indication, off-label use in unapproved indication, or intentional use for unlabeled indication? Let's see what you're going for. Yes, off-label use for unapproved indication. We know it is off-label. We know it was an intentional deviation by the doctor for therapeutic purposes. Exactly. Drug prescribing error would be incorrect. It's not an error. So it was a conscious decision for therapeutic purposes. Drug prescribed for unapproved indication is a neutral term, would not capture the fact that it was prescribed off-label, and intentional use for unlabeled indication could be used if it's not clear whether the deviation was really off-label or represented an off-label incident. So here, let me close the poll here and again use our decision chart. So here we know that it wasn't a conscious decision. It was a conscious decision of the healthcare professional, the doctor, with a therapeutic intention. So it's an off-label use. And we know that off-label use needs to be clearly described or mentioned in the reported, either in the report itself or even in the verbatim. We have this information here, so we can classify as off-label use. And if I now switch to the browser again and then look for off-label use, because this would be the main classification, I would look for a more specific term for off-label use. And here you see them: off-label use in unapproved age group, off-label use in unapproved indication, and also unapproved route of administration. So off-label use in unapproved indication would be the correct assignment here. And all other terms would not represent an off-label use as it was reported in our verbatim. So here we are. So the correct assignment here would be off-label use in unapproved indication. As mentioned before, if off-label use is not clear whether this is really a deviation from the local label, then intentional use for unlabeled indication would come into play, but all the others do not represent an intentional deviation. So it's not an error, it's not an issue, and product use in unapproved indication would be too unspecific as well. So we wouldn't capture the intentional nature of this incident. So here we are. We would code to off-label use in unapproved indication under PT off-label use. So let me continue with the last demonstration. Here we have a different scenario. Doctor mixed up the drug names because they look similar and prescribed the wrong medication. So was it accidental or intentional? He mixed up the drug names, so it was accidental. Who has caused the incident? The HCP, the doctor. Was it in the framework of therapeutic use? Yes, it was. At which stage in medication practice did the incident occur? Prescription stage. And here we have a root cause that was reported for this incident. So how would you handle this verbatim here? Doctor mixed up the drug names because they look similar and prescribed the wrong medication. So here split coding would become necessary, just a hint. Would you code wrong drug administered, wrong drug prescribed, wrong drug, product confusion, drug name lookalike, or drug prescribing issue? Which LLT would you select? Perfect. So most of you got it right here again. Well done. We have a root cause here. Let me close the poll. We have a root cause. The root cause is, there was a product confusion, but this would be too general. We can code this more specifically even. The names look similar. That was a confusion factor. So drug name lookalike would be the most specific LLT we could assign for the root cause. And this root cause led to the fact that a wrong drug was prescribed. So again, split coding would be necessary because we would need to capture the stage where what led finally, the root cause led to an error, and this would need to be captured. Drug prescribing issue would be too vague, and product confusion as well. So here our decision chart, it was an accidental incident. It was caused by the HCP, the doctor, in the framework of therapeutic use, so a medication error. And when I look into the browser again, then of course, we know that the root cause needs to be captured. And if we look into the medication errors, Here we have the confusion errors and issues, and it has to do with the name of the product. And if you open the product name confusion PT, you see the drug name lookalike. So this perfectly captures the root cause that was reported in our verbatim. And the root cause, this root cause finally led to the fact that a wrong drug was prescribed. Prescription and wrong drug. Here we are. Let's check for it. Here it is under PT product prescribing error. So here we are. Let's get back to our presentation. Here it is. So split coding would be necessary to capture the root cause and then the subsequent error that was made by the physician, capturing the stage where this error occurred. So both the stage as well as the specific error. Wrong drug prescribed. So perfect combination term here, and we would also capture the root cause. Here we are. These are the suggested proposals. So last chance for questions, Jane, for these demonstrations.
No questions, Caroline, on this.
Okay. So then this is a summary of what we have covered today. And I think we had one question regarding the self-medication, correct?
Yeah. How would you code self-medication if there was no further information given?
So here's the self-medication under this same PT, and if we do a right mouse click, go to browser, you see it's under surgical and medical procedures. So I would try to get more information, of course, if I get such a case without further information. It's just, of course, a patient can decide to do self-medication. It may have a rational background, but it could also represent or lead to a medication error, of course. So I would definitely try to get more information for such a case when you have no further information.
I think, Caroline, I wondered if the question was around whether self-medication infers that it's not come from a prescription, but I don't think you can say that. I don't think you could conclude that it was any more than self-administration.
No, it's just self-administration. Yeah, patient went to the pharmacy or heard something from a friend and would like to try something for a given condition, for some malaise or some adverse events he or she is experiencing.
Thank you.
Doesn't tell anything. Yeah.
Caroline, before you finish, can I just ask you to mention the video casts, the instructional videos?
Yes.
Because this week we've got the medication errors has been released just this week.
Yeah. So here we have the context, how you can contact the MSSO, and links to the MedDRA browsers that you can use for free. If you have a MedDRA license, you need the MedDRA ID and the password for them. Then the training schedule, very important, where you can see all the trainings that we also provide in different languages, like Russian, French, Spanish, Korean, Chinese, and a link to the MedDRA support documentation that I've shown you before on the MedDRA website. So this is what you see for the medication errors part currently on the training schedule page. So the next webinar will be on August 29th. So no other webinars are planned in different languages, but will definitely be offered in the second half of the year. Currently, it's not posted. And here we have the contact. If you click on contact, this is what I would like to show you. In addition, here we are. Contact. We have a YouTube channel, and if you click on this icon, then you see that here are the playlists, the recorded sessions of all of our trainers. So if you would like to watch a medication error webinar or any other webinar for coding instructions or for data retrieval SMQs, then refer to these recorded sessions, because you will find them in Russian by the colleague Yelena, for instance, or in Chinese, or in French by our colleague Francois, and also, where is our colleague Anna here, in Spanish, or also by our colleague Tomás Moraleda. So this is a really useful resource. If you cannot make it to a webinar due to schedule issues, you can always watch these recorded sessions on the YouTube channel. Now back to the question that, or the thing that Jane mentioned, training here. The instructional videos may also be useful for you. Here it is. You see what we have, as we have the MedDRA structure and scope, so very basic ones, one for overview on MedDRA coding and analysis, advanced coding topics, special situations, interactive MedDRA coding. Is it not yet posted?
Yes.
Jane?
It's special situations. Special situations includes medication errors with quiz examples, overdoses, and drug interactions.
Okay, it's not self-explanatory. Yeah. So this would cover, so it's a MedDRA fundamental, and will add some additional information to what you heard today.
It's a very useful summary after today's session. It uses your material, Caroline. It's a very useful summary with some quiz examples.
Okay. Yeah, I saw that before. I didn't know that it was released now. Congratulations, Jane.
Just this week. So.
After a long time. So with this, last chance for questions.
The only question is around making a change request. Dominic's asking us, so I think we'll follow up offline and send you the link to where you can go to make a change request. I don't think we'll cover that today. We're over. Just as a reminder to everybody, if you were here for the whole session, or if you just missed a few minutes, you'll be eligible for a certificate. You can download it after 2 business days from our self-service application, but you need to have been here for the whole session. So if you joined late, you may not be eligible.
Okay, so we made it nearly in time. So thank you for your interest in our topic today. Thank you, Jane, for supporting me as always. And yeah, I wish you a nice rest of the day wherever you are around the world, and hope to see you again in one of our other webinars. Bye-bye for now.
Bye-bye, everyone. Thanks, Caroline. Bye for now.